best corrected visual acuity. It is decrease in the best corrected visual acuity. In the absence of any organic disease of the ocular media, retina, and visual pathway. That means there is nothing wrong in the visual pathway. The media is clear, the retina is normal, the visual pathways are normal, okay, the brain is normal, but still patient has a decrease. This is called decrease in the best corrected visual acuity. Okay, decrease in fast. बंद कर दो. The decrease in best corrected visual acuity. So next we go. Suppose somebody has a refractive error. We give glasses. Still the patient is not improving. So this we call amblyopia, because there is nothing wrong with the eye, there is nothing wrong with the retina, nothing wrong in the brain or visual pathways. So once such a condition is there, this is called amblyopia. So there are different types of amblyopia. One is called, suppose somebody has skin, that's called strabismus. That's called strabismic amblyopia. Suppose somebody has a convergent skin or a divergent skin. So that is called an amblyopia. That eye will not improve to normal 6/6 vision. Then other thing is that you can have a refractive amblyopia. Refractive amblyopia means what? Somebody has a high hypermetropia, more than 4.5 diopters. Okay? Then that is called hypermetropic amblyopia or isometropic amblyopia. Somebody has a high myopia, more than -6. He or she can develop amblyopia if he or she does not wear glasses. Then we have one more that's called meridional amblyopia. Meridional amblyopia means patient has astigmatism. Why are you calling? Oh, madam, why are you late? Go ahead, sit. So this is called meridional amblyopia. Meridional amblyopia means what is astigmatism? One variation is normal, other variation is abnormal. Vertical variation is ametropic, horizontal variation is myopic or hypermetropic. So once such a situation, and if it is more than 2.5 diopters, how much? 2.5 diopters, then it can lead to amblyopia if the patient does not wear glasses. Okay? So remember these figures: 2.5 diopters of astigmatism, 4.5 diopters of hypermetropia, and -6 diopters of myopia. So these are the cutout levels above which the amblyopia can develop. Then we have one more amblyopia that's called stimulus deprivation amblyopia. Stimulus deprivation amblyopia. What's stimulus deprivation amblyopia? The light is not reaching to the retina. So once light does not reach to retina, the retina does not develop. It happens mostly in neonates or infants, where we have a mature cataract. The light does not enter into the eye. It does not reach to the retina. So they develop an amblyopia. Suppose after some time, even if we do a cataract extraction, we put the so this is called stimulus deprivation amblyopia. So due to cataract. Other causes which can lead to stimulus deprivation is where the media there is something with the media. Media means light and retina. So they can be corneal passages. corneal opacity. Natural cataract, I told, that there could be a vitreous hemorrhage or vitreous opacity, which can lead also to amblyopia. Which can lead to. So these three things, corneal opacity, macular cataract is more common. So macular cataract, corneal opacity, and vitreous hemorrhage, they can lead to the stimulus deprivation amblyopia. Stimulus deprivation amblyopia. So I have discussed all of these: strabismic, stimulus, and isometropic. I will just explain. Isometropic, I told you, hypermetropic, myopic, and meridional. Meridional, I told you, did astigmatism. And isometropia is a unique term. And isometropia, suppose somebody is -4 in the right and left eye 6/6. So there is a difference in the two eyes. This is called an isometropic amblyopia. So -4 eye, that will develop amblyopia. That will develop amblyopia. Amblyopia, other name is lazy eye. What is lazy eye? Because that's not used, because there is some blur, brain ignores that image, that blurred image, and that leads to what? Sort of the person is not used to use that, and it becomes a lazy eye. So basically, what is the pathogenesis of amblyopia? Pathogenesis of amblyopia is the physiological. It is a physiological. Physiological means the neurotransmitter level. Neurotransmitter and neurodevelopment of the vision is not properly developed with time. So there is a problem with the blood image of the retina, which leads to less stimulation of the central nervous system, which leads to decrease in the vision in that time. Is it clear? Next. So I told you about the second that can lead to this cataract. And one more thing is, I forgot to tell you, is even if there is some ptosis, ptosis, the eyelid droops, that is also stimulus deprivation. That's also stimulus deprivation. That's the fourth cause. Like this patient who has the lid is drooped here. So this can cover the pupillary axis. This can cover the pupillary axis, which can lead to amblyopia. High refractive error, I have told. Bilateral embryo, okay. High refractive error again. Meridional error. These are some of the risk factors where you can develop amblyopia more common. If there is premature birth, or the birth weight is less, or there is a family history, or there are other pediatric developmental anomalies. So that can also this. So how we clinically diagnose amblyopia? How we clinically diagnose amblyopia? So one of the criteria, very important criteria, is that the vision is decreased. Visual acuity is decreased on Snellen's chart or any others. How we define that? We define amblyopia in the terms of vision on the Snellen chart if it is less than 6/12. How much? 6/12. So if it is 6/9, it is not amblyopia. Okay, so less than 6/12 or 6/18, you can tell it's a bilateral amblyopia. Suppose one eye is normal, 6/6, and other eye has amblyopia. The way I told you, there is an asymmetric amblyopia. So how to define that? The definition for that is there should be a 2-letter difference. There is a 2-letter difference. That is 2 lines difference, I mean to say. Suppose one eye has 6/6, other eye has 6/18. Okay? So there should be 2 lines difference between the 2 eyes. That qualifies for a unilateral amblyopia. If it is a bilateral amblyopia, then the vision in both eyes should be less than 6/12. Okay? And other important thing is the fixation pattern. Suppose eye with a decreased vision or a lazy eye, it does not fixate properly. Once you throw the torch, the fixation reflex is not on the pupil, center of the pupil. The eye deviates. Eye is lazy. It does not take fixation properly. Suppose a child is a pre-verbal, he does not tell us vision. Suppose we see that the fixation is not there, torch fixation is not there on the center of the pupil. With that eye, we say that this eye can be amblyopia. This eye can be. So fixation preference is very important. The other test is the density filter. This is a sort of filter we put. It has been seen in amblyopia, the vision can improve. Vision can improve after putting a neutral density filter in the trial frame. So one more is the crowding phenomenon. What is the crowding phenomenon? You must have seen that there are several charts A, B, C, like whatever A, B, C, D, E, F, like that. Suppose you tell the patient to read V, H, M, A, I, X, U, Y. That's the last six slide. V, H, A, I, X, U, Y. If you tell him the whole line, he will not be able to read. Now you stop. You tell him one letter one. V, he will be able to read. H is called crowding phenomenon. Once you show the whole line, he will not be able to read. But once you show the individual letters, he will be able to see. This is called crowding phenomenon. So once you show him the individual letters, he will read it. Once you show him the whole line, he will not be able to read it. This is called crowding phenomenon in amblyopia. So what is called crowding phenomenon. Fixation patterns I showed. Then there is one more thing. There is one more important thing, that child with the amblyopia, he can have poor fixation. He can have a head tilt because it's not seen clearly with one eye. So he can tilt this eye with the vision towards that. Then he can have, suppose you in the two eyes. If suppose I have to tell that window how much its one bar is above that glass, it needs a bilateral normal vision. Bilateral vision gives you a depth of millimeters. So one eye is, there is problem with the one eye, the vision is not normal. There will be problem with the depth perception. Because depth perception is the function of bilateral vision. And once you have one eye only good vision, it will affect the depth vision. So this is one more important problem with the amblyopia. So most important, I told there are other types of amblyopia. One of the treatments for amblyopia is that we occlude the normal. We occlude the not abnormal. We occlude the normal. And there can be an occlusion amblyopia. There can be the eyes we are occluding. That can go into amblyopia. That can go into amblyopia. So you have to be careful how to do the operation. So treatment you have to start as early as possible. Why? Because first 5 years is the critical period. First 5 years is the critical period. In which there is the development of the retina and its neuro adaptation. So if during that period you are not treating the amblyopia, then you are not treating. Suppose the patient is refractive, the patient is not wearing glasses, that you are not treating it, it can lead to amblyopia. So, generally, previous teaching was that if anybody child is less than 10 years, how much? Less than 10 years, so it is a reversible amblyopia. It's a reversible amblyopia. If above he is above 20 or 30, it is irreversible. But present day thesis is that any age you have amblyopia, you treat it with occlusion. There is no age limit for treating the amblyopia. Because first 10 years, or first 8 years, or first 5 years, or first 10 years, they are crucial in vision development. Because retina keeps on developing even after birth. So, what can be the treatment of amblyopia? Suppose somebody has a cataract, stimulus deprivation amblyopia. So you remove the cataract. Okay? Somebody has a refractive error. You give him glasses. Suppose somebody has hypermetropia, you give him +3, +4 glasses, whatever. Somebody has a myopia, -6, -7, you give him glasses. Then somebody has astigmatism, and you give him a cylindrical glasses. -2.5 standard, 180, 90, whatever. Yeah. Okay? So somebody has ptosis, you correct the ptosis. Somebody has a corneal opacity, you do a corneal transplant. Somebody has a vitreous hemorrhage, you do a vitrectomy. So it is to be treated. It is to be treated. Now, patient has, we are giving glasses to the patient. We are giving the glasses, patient is not able to read about below 612 or below 618. He is not improving to 6.6. We do now patching. We do patching. Suppose left eye has 6 vision, right eye has 618. So we will patch the left eye. We will patch the left eye. So we will patch the left eye for 5 days, at least for 10 hours. At least for 10 hours. And one day we occlude the abnormal eye also, and one day we will keep both eyes open. Okay. So the rule of the thumb is we have to occlude the normal eye. We have to occlude the normal eye. That's very important. Once we occlude the normal eye, we have to tell the patient to use the other eye or fine details. Like suppose they can do separate minor things, different colors of pencils, different colors of beads, or even computers, games. They have to use the other eye so that it is stimulated. And there is a rule of patching also. What I told is 5, 5, 1, 1 open. This is once one eye is normal, other eye is abnormal, grossly abnormal. Suppose patient has 612 vision in the right and 612 in the left. There is equal vision. But patient is not improving beyond 612. That means bilateral amblyopia. In that we give 1:1 patch. One day right eye, one day left eye. Okay. It has to be a rule of thumb. Once the vision is same in the both eyes, the patching has to be 1:1. Okay. In between you can do. Suppose 3:2, 4:2. Then suppose one eye is 660, other eye is 66. You give 5, 1, 1. Okay. 5 days normal eye, 1 day abnormal eye, and 1 day open both eyes. Why we just shift for 5, 1 to shift? Why we are doing? Because if we do 6 days continuously, it can go in abnormal. Okay. So in order to avoid that condition, because I told there is a term what's called occlusion abnormal. That's called occlusion abnormal. So this was about the patching. And third important thing is that there is one more method to, if somebody does not want to do patching, that's called we put mid-rapid drops. We will mid-rapid drops atropine or cyclopentanate in the normal eye. So that the vision in the normal eye becomes blurred and the patient is in the abnormal eye. This is called, there is a term for this. What's the term? This is called penalization. Penalization. This is called penalization. This is called penalization. And lastly, some people have recommended some other therapies also, but what I have told, these are the gold standards, and they are time tested. And there is a problem in, there is one recommendation that full-time occlusion versus part-time occlusion. Full-time occlusion means from 9 to 5. 9 to 5, 10 hours of time. Some people recommend that we are unnecessarily because students have to go to school, it affects their activity. Some people recommend part-time patching. That's from 4 p.m. up to 10, like that, in the evening. So, studies have shown both part-time and full-time patching has equal results. It doesn't matter much, but the patching has to be done. And the third important thing which I want to convey you is the duration of patching. How long should be the duration of patching? It should be minimum 6 months. It is not 1 week, 2 week, 3 week, 4 week. It should be minimum 6 months. So you have to reassess the amblyopia after 6 months. Okay. This is how the patching is done. There is one more. Some people have put this as amblyopia also, toxic amblyopia, due to drugs like alcohol amblyopia, methanol amblyopia, or even some butol amblyopia. So these are some of the toxic drugs which can lead to amblyopia. Alcohol you all know, ethyl alcohol or methyl alcohol. Quinine you know is the antimalarial drug. Ethambutol you know is the antitubercular drug. So it can lead to amblyopia, toxic amblyopia. So next we go to the aphakia, which next topic is aphakia. So what is aphakia? Aphakia is a term which means absence of the lens. Which means absence of. There are three terms. One is phakia, that means presence of the lens in the eye. Other is aphakia, that means absence of the lens in the eye. And third is pseudophakia, that means artificial lens in the eye. So these are the three terms. So aphakia means when the lens is not present in the eye. What can be the cause of aphakia? Most important cause of aphakia is surgical. So we operate on the eyes in the children or in adults, and we are not putting the intraocular lens. That is called aphakia. Suppose if there is a congenital cataract, most of the authorities agree that up to 1 year you don't have to put intraocular lens. Up to 1 year. That is the present day recommendation. This is the present day recommendation. Up to 1 year you don't have to put the lens. So you give the patient aphakia. You give the patient aphakia. Student who are under. So this is the present day recommendation. After 1 year of age, you don't have to put the intraocular lens. So after 1 year, you keep the patient aphakia. Number 7 is suppose what are the other causes of aphakia. In some adults in which we are doing cataract, we are not able to put the intraocular lens because of posterior capsular rupture, vitreous loss, or other things. Maybe we are not able to put the lens, and this is called in adults also we keep patient aphakia. Suppose somebody has a trauma to the eye, and the lens is extruded from the eye. Okay, this becomes a traumatic aphakia. Then there are other causes of aphakia also, like if there is a dislocation of the lens, if there is a subluxation of the lens, the lens is not in its proper position, it is upwards, like the Marfan. Okay, even Weil-Marchesini syndrome, in which the lens is infranasally. So the optical axis becomes aphakic. There is one more. Suppose some patient has trauma and the zonial is ruptured, the lens goes into the vitreous. It becomes a traumatic aphakia, posterior dislocation of lens. And in the old time, there was one condition, one treatment that was called couching. There was one mm incision given temporarily, and the lens macular cataract was pushed into the vitreous. So the optical axis was clear and patient improved in vision somehow. So it was a very old pattern of cataract treatment. So these are some of the causes of aphakia. There are some of the causes of aphakia. But remember, number one cause is surgical. Number one is called surgical. So I told you these all. Next, what is the congenital absence of lens called? It's also called aphakia. What is cause? It's a genetic disorder. There is some genetic chromosomal abnormality which leads to non-development of the lens. Okay. So surgical aphakia, I told you. Couching, also we told you. Okay. मेरे हाथ से नहीं चल रहा है. Next. Up here you So once the lens is out of the eye, what will happen? what? Behind the retina. They will focus it behind the retina. So what it can lead to? It can lead to distortion of vision. Okay? It can lead to distortion of vision. What are the three cardinal signs of aphakia? Tell me.
Hypermetropia.
Hypermetropia. Okay. Loss of accommodation. Very good. That's very important. Because once the lens is not there, the news not there, it will lead to loss of accommodation. Third? Atropia. Okay, that we will discuss later. Don't tell high things. Tell simple things. I believe if you don't know simple things, you should not tell very high things. I will come to that thing also, but first let's clear. They can have a deep anterior chamber. They can have so deep anterior chamber because there is no lens behind eyes. So eyes is pushed back. So AC becomes deep. AC becomes deep. And iris, what happens to the iris? It becomes tremulescence. There is tremulescence of iris. Tremulescence. Tremulescence means it is vibrating. It's agitated like this. Okay? Once the eye moves, the iris gets agitated like this. It becomes tremulous. It becomes tremulous. So deep anterior chamber, tremulescence of the iris, and third, jet black pupil. Jet black pupil, because there is no lens now. The pupil becomes jet black. So deep anterior chamber, tremulescence of the iris, and jet black pupil. These are the three cardinal signs of aphakia clinically. And high hypermetropia and loss of accommodation and distortion of vision, they are additional problems with the aphakia. So if we now see the funds, what will the optic disc? That will be a hypermetropic small disc. That will be hypermetropic small disc. Because now the corneal rays are focused behind the retina. So I told you limbal scar, yes, in case of suppose somebody has been operated, there will be limbal scar there. Because that's mark of the surgery. Then retinoscopy is one more thing why you can tell the patient is the eye is hypermetropic. The eye gets focused at a high plus lens. Astigmatism I told you, it's not astigmatism, accommodation that I told you. And then now the focus of the lens. Focus, anterior focus of the eye and posterior focus of the eye. That is shifted. Why? Why that is shifted? Because the normal power of the eye is 60 or 65 diopters, out of which 45 diopters is given by the cornea, and 15 or 17 or 18 diopters is given by the lens. So that lens dioptric power is gone. Now eye is dependent only on refraction of the cornea. That is not sufficient. That is not sufficient. So anterior focus of the cornea or anterior focus that shifted from the cornea, that comes around 15. How much? 15 mm. And posterior focus that goes behind around 30, 31 mm. Okay? Because there is no lens in between. There is no. This you read the principal focus and the anterior focus and then posterior focus. Lastly, I will tell you about this term, atropia and synopsia. Atropia and synopsia. Atropia means it is restricted to the red color, and cyanosis is with the blue color. What happens to the aphakia? They see the shades of red and they see the shades of blue. Why? If anybody tells me, then he can or she can have a cup of tea with me. Don't say shoot. Anybody knows? If anybody knows, no side dogs. I don't like side dogs. I don't like side dogs. If anybody knows, he or she can tell me and tell me.
use rays so focus. Blue gets first in front of the retina, then red, then light.
No, not because. Basically, we have two more terms that's called spherical aberration and chromatic aberration. What is called? Spherical aberration and chromatic aberration. Spherical aberration means this is simple. So this is the lens. This is the lens. This is the lens. Those who pass through the principal focus, they will be straight. And those which pass in the periphery, they will be bent more. They will be bent more. So there is some distortion in the focusing conversion. Okay, this is called what? This is called spherical aberration. This is called spherical aberration. Another is chromatic aberration. The other is chromatic aberration. Chromatic aberration is some waves which have a longer wavelength, they are bent more. Okay, and which have a lesser wavelength, they are bent less. So it causes a chromatic aberration. Leave that aside. But one of the principal functions of the lens, one of the principal functions of the natural lens is it blocks the ultraviolet light and ultraviolet and infrared. It blocks what? UV light and infrared. So once there is no lens, they will pass. They will pass. And that gives rise to this Aphakia or synopsis. Is it clear? So normal lens has a capacity to obstruct these abnormal waves, to obstruct these abnormal spectrum of the light. Once there is no lens, patient can see a bluish hue or a reddish hue of the colors because they are not being obstructed by the lens which is absent there. I think I have made my point clear. And you understand why there is a reddish hue or there is a bluish hue. Now I will go to the treatment of aphakia. How we can treat the aphakia. So first line of treatment is glasses. Okay? What is this? Glasses. Second is contact lenses. Third is surgical. Intraocular lenses. Fourth is the laser-based surgery. Laser-based surgery. So I will go on to one. So let's talk about spectrum. Let's talk about the spectrum. What sort of spectrum do we give? We give 5 plus 10. Plus 10. Minimum plus 10. What? Plus 10. Suppose patient has now right aphakia. Left is normal. You cannot give plus 10 in one eye, 0 in another eye. Why? What is the problem in that? If anybody will tell me, I will appreciate. But get up and tell me, no gossip inside this. You know? Anybody know? Because once we are putting a high plus level in front of one eye, it will lead to magnification. It will lead to? So suppose I put plus 10 here, it will lead a magnification of the image. And other eye becomes normal image. What can happen? Brain will not accept it. Okay, brain will not accept it. Because plus 10 or aphakic glasses, they magnify the image by 25 to 23%. How much? 25. So if a person, this might it is enlarged 1/3 more. 30% roughly. How much? 30%. So brain does not accept it. Brain does not accept it. So it can lead to what? It can lead to suppression or amblyopia in that eye. So you cannot do. So what is the other option? Other option is the contact lenses or the eye lenses. But before we go to that, I will tell you something about the spectrum. Because we give, suppose somebody has bilateral aphakia. Both eyes, cataract surgery done, no lens put in both eyes, given plus 10 in both eyes, no problem with that. Okay? Because if one eye has more than 6 or 8% of magnification, other eye has normal magnification, it is not acceptable. Not to speak of 30%. Okay? So, bilateral aphakia, we give plus 10 in both. What are the problems with the aphakic glasses? What it can cause? distortion of vision. It can cause distortion of vision. Number one. Number second, it can cause diplopia. It can cause diplopia. Why these things happen? Because once the image is magnified, once suppose the cup is here, once it's magnified, it presumes to be closer to that. Okay, actually it is here, but patient sees it here. Okay, because of the magnified image, the problems are there. And one more is because of the periphery of the lens, that becomes prismatic. Once there is prism in the periphery of the lens, what it can lead to? That can lead to ring scotoma. What can lead to? Ring scotoma. Like this. This is called the ring scotoma. Suppose this is a vision, and so this black in the visual field, patient is not able to see, because it becomes a prism. Peripheral part of the lens becomes prism, and the rays are bent towards base, and they sometimes does not enter the pupil. And then this is called roving ring scotoma. What is called? Roving ring scotoma. Then one more problem is that's called, they have one more problem. Suppose it's a door. It's a door like this. Once they are entering that door, instead of straight like this, it appears that it is like this, convex. It appears smaller. So for them, practically no problem. They can see the door, but it appears as convex inwards, like this. Okay. And one more effect of Aphakia glass is called pin cushion effect. What is called? Pin cushion effect. What is the pin cushion effect? Pin cushion effect is, suppose this is like this. This is like this. This is suppose window like this. What they will see instead of this, because these bars are straight. They will see like this. As if they are curved. Like this. They will see like this. Because this is a pin cushion tone. Because it resembles like that. So it is called pin cushion effect. One more important is like this. This is the pin cushion effect. That is, the lines are straight here, but they are seen like this, as if they are convex inwards. One more is, apart from roving, first I told you magnification. Second I told you diplopia. Third I told you roving means scotoma. Fourth I told you pin cushion effect. And I have explained all this. And fifth is most important, is that's called Jack-in-box phenomenon. What's called? Jack-in-box phenomenon. That's very important. What does that Jack-in-box phenomenon mean? Jack-in-box phenomenon means, suppose there is some box here, and some toy is inside that. He comes up, lifts the lid, appears, and again goes down. Okay, again disappears. Appearance and disappearance simultaneously, or in a fraction of second, is called Jack-in-box phenomenon. It's called Jack-in-box phenomenon. Just I will make it understand. Suppose patient is looking straight. He has the Aphakia glasses like this. He is looking straight, and there is, suppose this area. This is what? This is scotoma. He is not able to see this. But this area he is able to see. He just sees this finger here. Because it is inside the scrotum. It is inside the scrotum. Okay? Now once it turns like this side, it disappears. Because the scrotoma comes down this angle. Alright? Something. I made a summary. Well, peripheral is scrotum. Something appears within that central field. But inside the scrotoma area. He is able to see something is here. He tries to see it, it disappears. Because the scrotoma shifts. Scrotoma becomes in that angle. Normally the angle at which the scrotoma is there, that's 55 to 65. Okay? Once it turns it, this angle changes. This angle changes. It goes between the 30 or 45. So it disappears. So we have seen this. Now we turn, it disappears. This is called jagged box. Is it clear? Yes. If anybody has confusion, you can tell me. Again I can explain. This is a ring scrotoma. Is it? Ring scrotoma. And something is appearing inside. Something is there. He is just noticing it is there. He is noticing it is there. Then once he notices, he tries to see it. Once he tries to see it, it disappears. Because the scrotoma remains. It becomes inside and it disappears. This is called jagged box phenomenon. And when somebody tells you to explain these things in the examination, you are wrong. You cannot explain what jagged box phenomenon. Students cannot explain. What pin cushion effect? Students are not able to explain. What is ring roving scrotoma? Nobody is able to explain. So you should understand it. You should be able to explain it if you are asked something. So after that, we come to the contact lenses. Contact lenses, they are put on the cornea. They are put on the cornea. This is a term that's called vertex distance. What is called? Because once the spectacles are on the eyes, what is the distance from the center of the cornea to the spectral plane? It's around 12. How much? 12. Then this is called vertex distance. It's called vertex distance. So if you omit this vertex distance and we put anything on the cornea directly, like a contact lens, what happens with that? The magnification gets reduced grossly. Okay? From 30% it reaches to 6% or 7%. Okay. That much difference in the magnification. So suppose somebody is living less than aphakia and he has other eyes 6 vision. You will not give glasses. You will give a contact lens. Because eyes cannot accept one eye having a very magnified image and other eye having a normal image. What are the problems with the contact lens? So first hygiene. Number second, technique. How to wear it, how to remove it. And solution. And suppose somebody goes to some relative or to some outing, he has to take all that kit, contact lens kit with him or with her. So that, because normally after 6, 8 or 10 hours, you have to remove the contact lens. Why? Infection is but not that much. There are some extended wear contact lenses which can be put for a long time. Because there are majority of contact lenses which lead to corneal hypoxia. They lead to because one of the supply for cornea is atmospheric oxygen. Oxygen supply for the cornea is one of the supplies is atmospheric oxygen. Once you are putting a contact lens on the cornea, it will obliterate that stuff. Okay? So cornea can become edements. If the contact lens is put more than 20 hours or 15 hours, that even overnight. So that can cause a problem. So it has to be put in the morning, it has to be put in the evening, and it has to be put in solution. And you have to wash your hands properly. Otherwise there will be many serious infections like even bacterial keratitis. And sometimes what can happen, the edge of the lens gets tall. Okay, that can cause corneal abrasions. And what does it can cause? It can cause allergic reactions in the eye, papillary formation in the dorsal conjunctiva. So these are the problems with the contact lenses. But if it's a unilateral aphakia, this is the best treatment. Even in bilateral aphakia, there is no problem if somebody is a very small child. You cannot tell him to wear the contact lenses. Or somebody is a very elderly, he is suppose 60 or 70. Do you think he will be able to put the contact lenses? No. So there are some limitations to the contact lens. So third option is the most important is the IOL implantation. It's the intraocular lens. We put in the lens in the eye, but for intraocular lens implantation there are some rules. Suppose you have posterior capsular anti, you can put a posterior capsular lens. Suppose posterior capsular is ruptured, anterior capsule is there, but you have made a capsular axis. So you can put a lens in that. That's called IOL in the sulcus. That's called IOL in the sulcus. Just I will explain. If we put lens between the iris and the anterior capsule, it is sulcus. If we put between the anterior capsule and posterior capsule, it is in the back. It's in the back. If there was no posterior capsule rupture, back, anterior and posterior capsule is intact, you can put in the back. If posterior capsule is not there, you have to put it above the anterior capsule. Between the iris and the anterior capsule, it's called sulcus. It's called sulcus. Suppose there is neither anterior capsule nor posterior capsule. What you will do? Where you will put the lens? You can put the lens on the iris support. You can put the lens on the iris support. That's called iris claw lens. What's called? Iris claw lens. We have both lenses, anterior iris claw and posterior iris claw. Presently, the posterior iris claw is preferred. Presently, the posterior iris claw is preferred because it is away from the cornea. It is away from the cornea. Because anterior iris claw, it was presumed that is closer to the endothelium, it will cause more endothelial damage. It is called more endothelial loss. And once there is more endothelial loss, it will lead to corneal edema. It will lead to corneal decompensation. So the plan, model of the surgery is gone. Once you have lost the cornea, then the second option becomes a corneal transplantation or an endothelial transplantation or a full thickness corneal keratoplasty. So if we are placing a iris claw lens at the posterior plane behind the iris and we are clipping on the two sides of the iris, it's a better position to put the iris claw lens. There are other lenses which what's called scleral fixated lens. What's called? Scleral fixated. So the loops of the lens on the two sides, they are hung from the two scleral ports, or they are sutured in the pars plana. In the pars plana. What's pars plana? Pars plana is behind the limbus. 5 mm. How much? 5 mm. 2 mm anterior is called pars plana, and 3 mm behind that is called pars plicator. That's called pars plicator. What's that? Why is that called pars plicator? That's because they have to realize things. We secrete the aqueous We secrete the aqueous So anterior plane, that's called pars plana. So in that pars plana, we keep the lens hung on the two sides by sutures. There is one more, you can make tunnels on the two sides. That's called glued eye. That's called glued eye. One more technique has recently come in these aphakic type where there is no anterior capsule, there is no posterior capsule. We make some strings of the rolling thread and we make knobs. And we pass through the lens and we pass it outside. We just put in just below the conjunctiva. Just below the conjunctiva, in the scapular bit embedded. Those knobs we make with the cautery, heat cautery. Not with the bipolar cautery with the heat cautery. So the lens in the eye, it is with the suture, and suture is outside the sclera hung. So it remains stable. So we have 4 options now. We have options. One more option is that's called anterior chamber eye. That's called, we put the lens in the anterior chamber above the eyes. But again, there is side effects like border edema. There is a term called UGH syndrome. What's called? UGH syndrome. Uveitis, glaucoma, and hygiene. Uveitis, glaucoma, and hygiene. That's more associated with the anterior chamber eye. So they have gone into disrepute. They have gone, because of these things, they have gone into disrepute. So we prefer an iris canal lens, or a signal fixated lens, or a glued lens, or this what we call this what we hung when we hung the lens in the threads, which are two knobs on either side. Last treatment for aphakia is laser surgery. Is it? Laser surgery. How we can give a laser surgery to aphakia? We can increase the power of the cornea. We can increase the power of the cornea. How we can increase the power of the cornea? We can do a hypermetropic lens. We can do a hypermetropic lens. In myopia, we flatten the cornea. Because cornea is always steep, we flatten it. In hypermetropia, we do opposite. We steepen the central cornea, okay? We steepen the central cornea and ventral cornea we flatten. So that the corneal power is increased. Corneal power is increased. Because there is a decrease in the corneal power, or we want more corneal power to add, so we increase the central corneal curvature. So there is one term, we can put some tissue on the cornea. We can put some tissue that will increase the power. We can take a donor tissue, donor cornea, we can put in front of the cornea. Okay? Suppose we put some stroma from other eye, we put in, make a pocket, we put it and then we suture it. It is called epikeratophobia. What's called? Epikeratophobia. It increases the central power of the lens. So, glasses, contact lenses, and intraocular lenses, and lastly, there is laser. So these are the four options in the field.